Hey everybody, Guy here from Chit-Chat. I just got done recording a really interesting podcast with my new friend, Rebecca. Rebecca and her husband started a clinic called Aslan Health about a year ago. And I don't think I know for sure that you don't need to work in healthcare. You don't need to work in medicine to know that the need in our community and in our country, in our world, in relationship to medicine and health is really, really great. And what Rebecca's doing and the vision that she has for how she can help people is really, really special. And so we got to talk all about that today. And I'm just thankful that there are people that give of their passion, their energy, their time, their spirit to making some of these really hard, complex issues in our world better and easier. And that's Rebecca. And so I'm excited for you to meet her now and to learn a little bit more about Aslan Health. Thanks for listening, everybody. Rebecca, thanks for coming to join us on the podcast.
Thank you for having me.
Okay, so Rebecca, you and your husband started a healthcare clinic recently. Would you tell me a little bit about you and tell me a little bit about Aslan Health?
Perfect. And so Aslan Health is a nonprofit primary care clinic, but it's a little bit different than regular primary care clinics. We're focused on those that fall out of the traditional healthcare system. And sometimes that can be a logistics issue. Sometimes that can be a model issue. It's just those that don't quite fit in to where the traditional model is. And so we take care with that as far as on the logistics side. We are more of a cash pay clinic. So we don't take commercial health insurance. We do take Medicaid and Medicare, but not any of the bells and whistles that come with with Medicare particularly. But our goal is those that don't have health insurance or those with a super high deductible. And so the cost of each visit is $75. And we also look at logistically wise because sometimes the appointment is the problem. Other times the appointment is needed. So a third of our available hours are for appointments, and the rest are on a walk-in basis. We have extended hours, so we're open till 7 o'clock most evenings and open on Saturdays. And so that allows the logistics side of access. And then the other aspect is our model of care is a little bit different. We focus on mind, body, and spirit, knowing that the medicine side is just a small portion of health. And so that everybody truly desires to be healthy. There's just obstacles in the way. And we try to find those obstacles and help you through them.
So I'm familiar with a model. So I like learning about stuff. I love learning things. In the last handful of years, I've learned a lot more about DPC, direct primary care, as kind of an alternative for some people to, I don't mean traditional medicine as in like Western medicine. I just mean like maybe like a traditional hospital or clinic kind of approach. Are you guys also a DPC? Are you direct primary care, or are you guys different than that?
So we are creating a model that would be more on the direct primary care model. Again, one of the things that we look at is what does the community need for those that don't have traditional healthcare insurance. And one of the gaps that we are seeing as we work with the community is especially with the small business owner or the entrepreneur or somebody that's running a couple side hustles as they put together what their model of a career looks like. Insurance is out of reach. And so with a direct patient care model or that DPC model, one of the things that it looks at as you're able to pay a membership, and in that you get a certain amount of healthcare practices, and whether that's visits or labs or general health wellness, and then all of that's incorporated underneath that model. What this allows is for someone to be able to carry catastrophic insurance. So, because it only takes one hospital admission to really bankruptcy people. When we look
Completely change your life.
yeah, exactly. The if we remove addictions from homelessness and look at the causes of homelessness, medical debt is the second leading cause of homelessness. And so we want to look at how do we disrupt the current system, and that is being able to offer people an opportunity to be healthy, because everybody desires to be healthy, yet still protecting them from that catastrophic. And so, so the DPC model kind of looks like your membership at the YMCA. You know, you pay a fee and you get a lot of services with that fee. The amount of access that you use is up to you.
Right.
Because I get lots of patients that tell me, well, I have a gym membership. Well, that's great, but do you go? And that's where we want to be able to offer a model to say that, yep, that's great. You have the opportunity, but how can we capitalize on that opportunity?
And so that's one of the reasons why you have extended hours. And I think I heard you say at one point, maybe at a chamber thing or something, that you guys made sure to pick a spot that was really close to public transportation, like really close to the bus stop.
Yep. That's exactly it. So in the Midwest, transportation is assumed in many cases, and that's not a reality for everybody. And when we were looking for a location, we wanted to definitely be on the bus service and be centrally located. And so downtown is one of the places that allows that. So we right next to the library, and almost all the buses in our current bus system go to the library multiple times a day. And we also have a bus stop right outside our door.
Yeah.
So we wanted to be on the bus line. We also wanted to be in a location where you could convince your neighbor to take you downtown versus convince your neighbor to take you way to the other side of town. And then you convince your other neighbor to come get you. Whereas, but if you're looking at a 30-minute, 40-minute transportation, you can't. It's not as easy to convince something to do that.
Yeah.
And so that's where our location is trying to remove that obstacle of the transportation to getting to the facility.
And are you a doctor? Are you what's your level of medical training? I don't even know exactly what the right way to ask that question is.
I'm a family nurse practitioner. And so what a family nurse practitioner is a different model of training to end up at the level of family practice. And so I started out as a registered nurse. And so I worked thousands of hours as a registered nurse, and then I went to school and got my master's. With your master's degree, I had 3 additional years of education and more hours of, we don't call it a residency, we call it more clinical hours. And then I also worked for 14 years in a regular traditional family medicine clinic. And
As an NP.
Yeah, as an NP. And so in the state of Minnesota, once you work 3 years underneath someone who's guiding you in practice, then you have an independent license. And so that allows me to have an independent license for the facility. I'm the only clinician at Aslan Health. We have 2 other doctors that volunteer time to help me to be able to run to speaking events and cross-country meets and things like that. But otherwise, I'm the clinician that's there.
How did you develop those relationships with these 2 other doctors?
One of them, I worked with him for years and years. We shared an office for a number of years. He actually really guided my practice as far as the way that his patients interacted with him is when I first began to practice was like, I want that, like that. And he practiced in the community for almost 30 years. And you can still hear people talk about when he delivered their babies or when he took care of them with that. The other was a friendship that developed. I've never actually practiced with her, but we developed with a friendship that then turned into, I really like your model of care, and I want to give back to the community, and so I want to get involved. And so then she became to come and practice with us.
As you, as you're in the community and you're at, a cross-country meet or whatever, and you meet other doctors and nurses that work in more traditional kinds of settings and they find out what you do, what is the response from other healthcare professionals?
It's usually sometimes they laugh and they say, that's crazy. Other times they really desire to help people. And people enter into the medical profession not to do lots of charting, not to
Paperwork.
exactly, not to run on that hamster wheel of trying to really keep their head above water. And they want to help people. And so we look at it to say, like, what is different that we could do even in our clinics versus to have to start a new clinic. That's a big step. But how can you change practice to keep forming the relationships, to take a pause and to be a good listener? And so in most of the time, it just leads to a conversation about how can I be the best clinician? Because I really do want people to be healthy. There's not a clinician around that says that, oh, my goal is to get you on lots of drugs and have you have lots of surgeries. That's not it at all. Sometimes it kind of feels that way, but that's not their goal. And to be able to design a practice to say, how can you be healthy? And how do we do that in the time that's allotted?
Yeah. This might be you might not have an answer for this, but obviously there are lots of things in, like in someone's body or in their kind of like healthcare journey that at your practice you can't, you can't be a part of. But do you have any gauge, just like percentage wise, what percentage of kinds of things could someone, like deal with on any given day, that you guys can do at Aslan in comparison to where you would actually need to go into, a much bigger, more robust kind of medical system?
A very high percentage.
Yeah.
The majority of things are under the primary care label. So primary care or family medicine is a broad category. When we talk about primary care, it incorporates family medicine, internal medicine, pediatrics. And so when we look at that category, everything starts there. And then you look at the specialists then would take just a small portion of that. So everything would start in primary care, and then we recognize, well, you know what, I think I need to get a cardiologist involved. But the primary care never steps away. So the cardiologist never takes the patient and solely is responsible for that patient, because if the patient gets strep throat, the cardiologist doesn't deal with the strep throat.
Yeah.
It comes back to the primary care.
Yeah.
The other aspect is we look at primary care more as the ringmaster of a circus of health. And when you go to the circus, there might be many rings that are going. So the patient might have a cardiologist, they might have a nephrologist, they might have an endocrinologist, or all different specialists. But to truly achieve health, they need a ringmaster that is able to translate sometimes, because a cardiologist is very good at the heart and the circulatory system. And sometimes being really good at something makes you speak in a language that the commoner doesn't understand, because you do it every day. And so those will come back to the primary care and will say, did you understand what the cardiologist was telling you about? And how does that relate to what I'm going to decide to eat for supper tonight? And how active am I going to be this weekend? And what other things can I do in life that helps me to avoid that next surgery with the cardiologist? And so the primary care is involved in everything as the starting point. And then also just in general health. It gets to be almost like a member of the family. Like many times I would get brought the funeral flowers because you played such a great role in their family, or you get a Christmas card because you are an integral part of their family.
It's a pretty remarkable honor, I'm sure. You have a kind of access into people's, most intimate thoughts and the things that they're the most worried about. And I'm guessing that you get to be a part of some really, really remarkable conversations.
Story is the driving force for us here at Switchboard. Story is also the reason that Chit-Chat exists. We tell stories of the people around us through photos, videos, branding, and websites. Story helps us find meaning, and it draws a community together, and we would love to help tell your story. You can find us at www.switchboard.mn. We would love to meet you. We'd love to talk with you and learn more about the story that you are trying to tell and how our story-driven marketing tools can help you communicate better. Can't wait to talk to you soon.
So you said that Aslan Health is a nonprofit. Would you tell me a little bit more about how it runs as a nonprofit? Are there clinics that exist like this that aren't nonprofit? They're actually for-profit businesses, and why? Why did you choose the nonprofit route rather than just starting a clinic in a unique kind of way?
So our path, I'd never dreamed that this is where I was going to end up. I never thought when I was going through school, someday I'm going to own my own clinics. In fact, I had absolutely no desire to do that. I knew that I was going to leave corporate medicine when I hit 50. Corporate medicine is very stressful. You have lots of moving parts and lots of stress that comes along with meeting expectations, not just for your patients, but also there's lots of support staff that depend on the revenue generators, and then there's all the systems with insurances and things that the corporate medicine has to do to keep the lights on. With that, we have a very good corporate medicine system here, but I was able to see different areas where people were falling out of that. And so I always thought I would leave corporate medicine and do humanitarian medicine.
Like overseas?
Like overseas, yep. Low resource medicine. Low resource medicine means that you're bringing medicine to somebody who doesn't have thousands of dollars to pay for that surgery or to get that drugs or to be able to have access to the pharmaceuticals reliably. And so you look at what can we do with what they have and meet them where they're at, where they have. And so with that low resource medicine, I spent years training, thinking that I was going to go to the high Andes and to the corners of the world. And a couple of years ago, we say that Jesus put us on the bench. We had our life, we as being my husband and I, life was running at 10,000 miles an hour, and we needed some margin in life. And so we started unwinding what we had been involved in. Because that takes a lot of time. I had stepped down from administration at Center Care. We sold our bees. We used to be commercial beekeepers. We, stepped off of boards and things in our community, waiting to figure out what was next. And then started looking for a common ministry. So we're a nonprofit because we're a faith-based clinic, or we're focused on caring for people as Jesus cared for people, and meeting people where they're at. Because when we look at Jesus' miracles, a lot of them involved healing, but it was where they were at, and he asked their questions, and he listened to their response. And I'm definitely not a healer, but I can help you be healthy and meet you where you're at. And in doing that, we looked at, well, what kind of things should we start with that? And I was listening to a podcast one day, because when you run clinician side of things and administration side of things, you're involved in lots of what's going on in the clinic, and people stuck their head in my office all the time and interrupted. So I'd be interrupted like 70 times a day. And so I would put earphones on, so I could someone would peek in and say, "Is she in a meeting?" And I would listen to podcasts while I was trying to chart between patients. And I ran across a podcast of a doctor that was in Denver, off of Colfax Avenue, and he does low resource medicine right in the middle of Denver. And Dr. Palmer is his name, and he runs an organization called Mango House, where he's a for-profit clinic, but he only takes federal and state insurance. So he doesn't take commercial insurance. So I text this podcast to my husband, Clay, and I'm like, I think this is it. And he texted me back and said, I think you're nuts. And so, and that's exactly it. But then I got home that night and he's like, well, I've been praying about this and Jesus doesn't think you're too nuts. And so we started looking. We did find a like model clinics, lots of them actually, in the United States. There's not a lot in Minnesota, but there's a clinic in Memphis, Tennessee called Church Health that it takes care of 68,000 uninsured Memphis residents. They're 37 years old. And so we contacted them and said, we really love your organization. And they're like, we are trying to get our model all over the United States. Come for a replication seminar. And so we traveled to Memphis and they took us to the beginning of their clinic and has really been instrumental in helping us take that model here of how do we serve a population that will be transient in some cases through their time of need, but there's other people that will stay in this uninsured population with it. And so that's kind of where it developed as a ministry and as a nonprofit. And we really want to work to meet people where they're at and then carry them to their next stage in life.
So you said 60, that clinic does 68,000 a year?
Well, they have a 68,000 patient panel.
Okay.
And so I'm not sure what they do for yearly encounters.
Yeah.
But they have a eye clinic and a dental clinic and then they have a great system developed with their neighboring systems. So they have orthopedic doctors that volunteer time and they're able to fill in the gaps of the specialties too with it. And that's where our goal would be to look at is not to take care of 68,000 people. We don't plan to get that big, but to be able to create a network that capitalizes on people go into healthcare. So all of the nurses and the doctors and the pharmacists desire to help people. And how can we help have a road for them to help the people that are falling out of that traditional system?
At Aslan, how many clinicians could you see it eventually growing to? Is there kind of like an ideal size for a clinic like this?
Our goal would be to stay a small neighborhood clinic.
Okay.
And so we would look at the size of our building and say that 3 clinicians would probably be the max that would run 3 full-time clinician positions in that building. And if we were to ever grow out of that, we'd look at another small neighborhood clinic because being a part of a neighborhood, being easily accessible are 2 of those obstacles to healthcare, that being a part of a large organization where people have to go to a big building and lose some of the personal touch would fall. Like that's not our goal is to be, and there's nothing wrong with that as that aspect of it. Was just we want to stay as a small neighborhood clinic. And so if we were to grow, I could see we having a smaller clinic in another part of St. Cloud or in another neighboring community to allow that access to healthcare. Because if we look into neighboring communities, now they have a longer drive to get to healthcare.
Yeah.
And if you don't have reliable transportation, then that's not a choice that you make. Or you have to take a half a day off versus taking an hour off. And if you're a low to medium wage earning workforce, if you don't go to work, you don't get paid.
Yeah.
And so it's not as easy as I'm going to take the afternoon off because that may mean you don't have enough to make rent.
Yeah.
And so it's a big decision to make when you don't go to work.
As you're looking at your current, client or patient customer base, what percentage are? So I've come and seen you a couple of times, and I have insurance, but I have a high deductible plan, right? So what percentage are like me, and what percentage are, no income or low income, individuals?
Most that come to see us have income.
Okay.
With that, most are that working population
Okay.
that don't have health insurance. So we're just running our yearly numbers. So on August 1st, we'll be open a year, and about 80%, about 84%, I think was the last number, is the uninsured that come in, and then the rest is those that have insurance that. So 80% are paying cash that day. About 30% of those have insurance that have the high deductible. And then that leaves that 20% that were Medicare and Medicaid.
Okay.
Is kind of a breakdown that we're getting right now. With the high deductible, it's a really hard thing to be able to draw a line with have insurance, no insurance, because there's two realities that are current. There's a reality that the average insurance deductible has increased to about $5,000. And there's some that have a large deductible, like a $10,000 deductible. But the other reality is the average American has less than $200 in their savings account. And so if you have a $5,000 deductible and $200 in your savings account,
You don't have
it's
insurance.
like not having insurance.
Yeah.
Exactly.
Man, it's such a complex, it's such a complex problem. I think the reason that I'm in a number of, I shot a video for a DPC clinic, and I went from not knowing that DPC existed at all to just like really thinking it was really, really cool. And I think in part just because the issue in our country around healthcare and people being, like having it being accessible in some kind of even remotely reasonable way seems so daunting, and the problem is so big. And so I love learning about the DPC thing, because it's like, okay, well, here's just another option. Like, again, it still might not be right for everybody, but there's at least a segment of the population that was going to struggle getting access to healthcare in some kind of way that could, gain more regular access in this kind of way. So I love learning about all these different ways, and I'm so thankful that there are people like you, and again, even in our kind of traditional, I wrote the corporate medicine kind of model, who really do care about some of these marginalized people that keep falling through the cracks and end up, uninsured, underinsured, and subsequently not going and receiving healthcare. One of the things that you were saying made me think. I just got back from a trip in Ukraine, and I was shooting a video, and I met a really, really sweet, incredible man named Volodya on this trip. He and I was gone for a little over 2 weeks, and he and I were roommates for the majority of that time. And he's like maybe in his mid 60s. He was our translator. And I just fell in love with this guy. So unbelievably sweet. And I called him Rumi. And so he and I, for this 2 weeks, this little team was together, and he and I called each other Rumi. And he's just sweet and kind and wonderful. And Volodya lost his wife about 5 years ago, and she died of cancer. And the way that he talked about the cancer journey was so different than the way people talk about the cancer journey here. And again, this probably happens here as well in some capacity, but I had never engaged with someone before who said, I found out that my wife had cancer, and since we can't afford any medicine, we couldn't afford chemo or radiation, we just went home, and he was with her while she died, and they just waited for the cancer to take her. And without any sort of like traditional, like we fought in these kinds of ways. I've never met anybody. I've never, in all of the conversations I've had, and we all, think of how many people that we know who have cancer. I've never once had that conversation. And so again, I even that made me thankful in some regard, or in a lot, for being in the United States, and in spite of some of these challenges we have in relationship to healthcare, I had never met anybody who just found out that their loved one had this horrific disease, and well, since we can't afford that because it's just for rich people, we're just going to go home and die. And so I am thankful that we have access to that. So there are people in corporate medicine too that are just that are giving and caring, but I love that. I love what you guys are doing and how you're trying to help. Obviously, there's too much. Like in a community of our size, St. Cloud is what, 60, 70,000 people, and depending on how big you draw the circle, St. Cloud is 150,000 ish. There's way too many people for you, one practitioner, to do that. Are you hoping that Aslan can grow soon? When you think about some of these like possibilities of other clinics and these little neighborhood communities, which I love that. I love that idea rather than growing a big giant building and a big giant system. I love that little idea of little pockets. How soon do you think something like that could happen with so much need all around us?
I think that so we're very calculated as individuals, and so when we look at hiring people, it gets kind of scary. But as we move forward with that, most like clinics hire another at least part-time clinician within a year to a year and a half of opening, and we're there with that. We're looking at bringing on more staff coming this fall, as far as a nursing staff or medical assistant, or because right now it's a very intimate relationship. I take you and take your blood pressure, and then we go to the exam room, and then I draw your blood, and then we take care of all your lab callbacks and follow-ups and things like that, which I really, truly enjoy that, though. I think that it allows me to be very close with each individual patient. You get to know them and know where their obstacles are, and how can we do more than just give the right medicine. How can we help you live the right life? And that looks at everything from how you're eating to how you're moving to where your emotional state is to how you're sleeping, because all of that really goes into health. But as we grow to expand with that, we would like to hire another clinician, at least part-time, in that year and a half from opening. So August 1st will be open a year. Our goal was to be seeing at least 37 patients a week, because we're open 37 patient-facing hours. That just means an opportunity hour for someone to come into the clinic. Because primary care takes a little bit to grow, to people to know about you, and then to be comfortable with you being their health care with that. But we've increased about 30% every few months. And if we continue with that growth, we won't be able to keep up in just a few months with it. And so there is a great need in our community. The United Way does a great calculation that's called the ALICE population. The ALICE population is asset limited, income constrained, employed. And this is a population that is working really hard. Usually they are a wage earning workforce, and they could be even in that medium to high. So to come into what's called the survival income in the ALICE population, the adults in your household need to make less than $30 an hour. And so if you look at the combination of adults in your household making less than $30 an hour, that encompasses a lot of households in the greater St. Cloud area. Actually, I think it's about 30%, and then 15% are below that poverty line. But there's between that 15 and 30%, these are all adults that are on a survival budget. On the survival budget, it means that each month all the money is gone by the time you reach to the end of the month for basic needs. And so if your car breaks down, if you have to go to the clinic, if you have a birthday weekend, so you spend a little bit more, you're running out of money by the end of the month. And so it incorporates a lot of St. Cloud. And one of the areas that it's highly is female-run single adult households. 75% of the single of the single adults, so the one mom in the household running with multiple children are below that survival budget line. And so these are the people that are the need that drop out of that healthcare system, and they need the after-hour care when you stop at the daycare and then they're like, and your kid's got a fever.
Yep.
They need a strep test before they can come back.
Yeah.
And so
So
what
if
do
the
you
clinic
do?
closes at 5,
You're sitting in urgent care, and that's just a really hard place for someone to be, knowing that they're going to urgent care. Their bill will be probably $300 on the low side, $500 on the high side, and now they're really going to be strapped at the end of the month. Yet they have to go to work tomorrow,
Yep.
so they have to be there today, because if they missed a whole day of work tomorrow, then
the bill doesn't cost $300 to $500.
Yes.
It costs $300 to $500 plus a day's wage. Yeah.
And so the need is great with that. And so we want to be able to expand to fill the need as good stewards of, because we're a nonprofit, of those that are supporting us. So we will be a slow, controlled, calculated expanse.
That's great. When you say supporting, so because you're a nonprofit, like, have you guys raised money, or is part of your funding strategy through donations and gifts?
Basically, all of our funding strategy is through that. Right now, we are donor funded. And so 80% of the care that someone receives when they come to our facilities is from donors, and the patient pays for 20% of that care.
Wow.
And that's a model that the other like clinics in the nation utilize, and we're able to create that 80% through donor base. We are applying for grants, so there's opportunities for the grant, but you have to be open to apply for grants, and then that's a whole learning process too. But as we look at being good stewards in making sure that we have a longevity plan, you can't totally depend upon grants, because grants come and go with that. And so budget-wise, we wouldn't want more than 20% of our budget to be from grants. And then foundational support. So we have a few foundations that support us. We have a few local churches that support us on a monthly basis, because we're looking at care in Jesus' name and being able to really take care of the person that's sitting next to you on church on Sunday, because that same 30% of the population that needs our care are the 30% sitting with you in church. And so our local churches are another area that we look for funding. But right now, it's primary individual donors is who is funding the clinic.
It's really cool. And if you're a nonprofit, obviously you guys have to have a board.
Yep.
How did you pick your board? Are your board members, are they medicine people? Are they, how did you pick them?
And so we talked to a lot of people, and the people that were most engaged is the people that were like, would you like to be even more engaged?
That's great.
How we did. So we're a board in the state of Minnesota. There has to be licensed people on the board with it. And so eventually I'd like to be off the board, but right now I am on the board and the medical director aspect of things. And so I'd like that to be two separate positions, but in time that will be. So we have a medical person on the board, we have a pastor on the board, we have an accountant on the board, and a lawyer on the board.
Great.
We really looked at who loves people, loves what we're doing, is engaged in helping our community. Most of the board is from our community. One is from outside of the community, but most is from the community. So they want a better St. Cloud, and they truly love St. Cloud. And in doing that, it means how can you make it better from within? And so that's how they ended up on our board.
That's cool. Well, sweet. Rebecca, I'm thankful for what you guys are doing at Aslan Health. If you're listening and you, either just want to support a really neat opportunity to make an impact in our community, you should look up Rebecca and her husband Clay at Aslan. Or if you have a high deductible plan, you should go and see Rebecca. She's great. I can say this, she can't say it, but I've gone to see Rebecca twice, and it was was quick and it was easy, and I got great care both times. And so I absolutely would recommend, in any kind of way, in lots of ways, you should go and check out what Rebecca and their team are doing at Aslan. But thanks so much for coming and joining us on the podcast.
Thank
It's
you.
great to hear a little bit more of your story, and we'll be rooting for you.
Very good. Thank you.
Thanks. Hey, everybody, just a quick note. I'm recording this after I recorded the podcast with Rebecca, and she sent me an email after our podcast. This is the first time in 80 some odd podcasts, however many we're at right now. This is the first time this has happened. And Rebecca had mentioned that I made a comment in our episode where I was talking about my friend from Ukraine, who, because of the nature of healthcare in Ukraine, when his wife was diagnosed with cancer, that they just, because they couldn't afford treatment, that they just basically had to wait for her to die. And I had mentioned how, something about how that caught me off guard because I didn't know anybody who had ever had to choose like that. And she just, in an email, just really sweetly just reminded me that there are tons of people in our community all the time who make decisions like that. And so she really kind of graciously and carefully kind of corrected me in that thinking. And so I just wanted to just say here now that I received that correction, but we wanted to keep it in the episode just because it was a part of that real conversation, as is learning and growing. And so I'm thankful for Rebecca and her time coming on the podcast, and for her being willing to be like, hey, I thought more about what you said, and I think here's a better way to think about that. So again, thanks for listening. I absolutely love that you guys are here listening to the podcast and joining us in this kind of exploration of all the people in our community that are making St. Cloud better. And Rebecca is for sure doing just that. Thanks, everybody.